So, I was listening to a number of the impressive achievements the state has made. A role I have served even now as chairperson of the advisory committee is actually to point out some of the problems that you are having, the challenges you are facing, and the future directions that you need to go. I would have liked to have shared the full details of the CMCHIS report of the committee with you, but it's still not in the public domain. But there are certain insights related to primary health care that I would very much like to share with you because of this particular reason. I'm therefore going to take my 10-15 minutes and to actually talk about this problem of primary health care. Because I noticed that even in this audience, we are all primary health care, but the interfaces that we need are not in the room. So we call this preventing fragmentation of care, building synergy between the different components and moving to the right to health care. Why is synergy required between primary health care and secondary and tertiary care? We do our thing and they do their thing. Is that not enough? But we know it is not enough. There is no effective primary health care which is not backed by appropriate secondary and tertiary care. You take care in pregnancy. You spend so much time doing antenatal care to detect complications. But if you detect complications, to handle it requires secondary or tertiary care. Otherwise, the lives you save will be very limited. This is true for almost every other area. Okay. And the second thing is that for a patient, if I am a pregnant woman or if I am a person with the diabetes and a cardiovascular condition, I require follow-up at different levels. I am not bothered whether this is primary care or secondary care or tertiary care. Sometimes I need a specialist, sometimes I need just to take my regular medication. But if my regular medication is at one department and then my specialist care is another department and they don't connect, continuity of care is not established. And when we talk about this notion of people-centered healthcare, this is a big buzzword around. What we really mean is how do you break fragmentation and ensure a continuity across the boundaries of care providers. And it's not as if it is only you who require CMCHIS help. I can tell you as chair of the committee, the CMCHIS desperately needs your help also. And therefore, working together is 1 + 1 is 3, or I would say 1 + 1 is 5, not just 2, because the coming together is giving an added value that both by themselves cannot give. Now, the strengths of the Chief Minister's health insurance scheme we all know. For one thing, it has legitimized financial protection as a goal. Before also we practiced it, but now there is an acceptance of it. It has improved access, it has annual performance in numbers is huge and impressive. And there is a mix of services available now with the public provider. Before, the public hospitals would not get into high-end quaternary procedures. They would be doing ordinary level secondary care. But whether it is a joint replacement or a liver transplantation or a renal, the public sector has been incentivized and motivated to come in. And this whole new medical colleges you have built depend critically on CMCHIS to provide the range of care. It has made a template of how you can engage with the private sector. It has put in place the dimensions needed for universal health care, digitization, monitoring, grievance redressal. There's a very good interface with an independent emergency care system and a huge number of quaternary care also, what we call, in place. So, I am going to talk of the problems, but please remember, I said good things about CMCHIS before I went into the problems, because sometimes we get a bit challenged when we talk about that. But there are limitations. If we don't understand the limitations, we cannot move. To a small percentage, getting a card is still a problem. 12 years after we started out. And many services are not part of the package. So if I go to a public hospital, only about 20% of services are technically, even by rules, qualified as part of the package. In a private hospital, the access may be less. Locating a provider is not an easy issue, because for this particular treatment that he requires, which provider offers care under the scheme is a non-trivial question. Even doctors guiding them doesn't know it. Public provider denial has been a problem despite a clear rule that no person can be denied care due to the absence of a card. There are still many micro level problems why it occurs. Private provider denial can be even the norm. Insurance denial because of so many procedural papers. So if there is a delay in filing the papers of 48 hours, then it's denied. But as you have argued that the entitlements of a patient to care cannot be abridged by the failure of a procedure by a provider, and therefore there are issues on that. And finally, denial of cashless care, though there is the norm. But what can primary care do about it? I do not say they must do about it. This is something that you can do even now without any government order. You don't need a government order to do it. But there is a role of government orders and there is a role to make it obligatory, and one must see on this. First, I don't see why there should be anybody without a card or referred without a card, because you know the population in your area, you have made population-based registries in some place, and it is not too difficult a matter to check whether all of them have a card, especially if we universalize, but even otherwise. Second, there are many functions you do, like pregnancy registration, like registration for non-communicable disease treatment, for medication of compliance. Whenever you make a reference, why should it be that you refer a patient with a CMCHIS card and the patient goes to the hospital and there he is told that you have not brought the card? If you have made the reference, it would have been worth your while to remind the patient of do so. And there are so many IDs, patient IDs floating around. You need to make sure they are aligned at some point. And the worry is not that our coverage is weak. The worry is that some of those missing the card are the most vulnerable. So I am not worried that some people are not having the card or making misuse of the card. I am worried that some of the people who desperately need the card otherwise will not get any treatment, and these most vulnerable, only you at the primary health center know the migrant community, the illegal migrants, many different people who are there and not categorized, and you need to map the vulnerable in your area. This is much more a problem in the urban PHC, where you have homeless people, you have street children, and at some point the notion of vulnerability requires the primary care provider to have a special attention to it. And finally, our messages on basic health education do not even tell what are the details of the entitlements under the scheme. If they face a denial, they don't even know why they are denied or what they can do to avoid that denial. So I think the primary provider as friend and guide, as a family provider who is a help to them, is a role that we must all uptake as one of the central roles of primary providers. But then there is another role, the role which in international journals you will find it under the role navigation. Navigation we use for ships. But even in the USA, navigation is an important role of primary care provider. When you go with, suppose you have been detected with a breast cancer suspicion, where to go, how to get care, if they delay, what do you do? If they say, no, come after 1 week, we need those tests, what do you do? How do you cope with it? Finding the appropriate provider is a challenge. It is not possible. People tell me that you can go to the website and see. I can't find it out from the website. There is a call center that is effective, but don't expect the patient to ring up the call center. Your staff, your providers in the hospital can ring up the call center and see this patient seems to have glaucoma. Where should I send him for a good glaucoma referral? That facility is available. Never refer a patient without knowing where to refer to. And every primary care provider must have a list of priority sites for the appropriate referral for each clinical difference. All referrals must be facilitated and no denials due to a lack of card. So at this complex is something that the primary care provider, we are referring. It's not that we are not referring. We are making referrals every day. But exactly having in the district a card devised for every primary care provider so that he knows where to refer is another thing. And you know, there are NGOs that are providing referral for ethical providers. There's one NGO in Dindigal, Piney area, which rings up, people contact them, they say, go here, they don't make the charges. Don't go there, they will make charges. If they can do it, certainly we should be able to refer and look at the rate parts. The second set of problems regarding CMCHIS relate to the fact that they have a budgetary constraint. Eventually, the package is small because the budget is limited, and therefore a number of techniques are used to keep it within the package. Now, there is nothing much we can do with the CMCHIS budget, but one thing is there. A majority of the cases that go there, the caseload of cardiovascular and this could definitely have been reduced. But very selective care, supply side inequalities, insurance, package rates. These are the problems of CMCHS. Now I come back to what will synergy with the primary care provider do for these problems. The first set of problems related to the card and access. These are supply side problems. One important point I wait to make is that synergy is life-saving. In the 30 to 70 age group, Tamil Nadu has a very high level of what is called preventable mortality. And within that, the death rates of men are 3 to 5 times higher. We have a scheme from the Chief Minister for providing support to single women households. But many of those single women households are not single due to desertion. They are single because of death, premature mortality, which is largely cardiovascular in origin, but it is also renal in origin. When I was visiting places as part of the committee, I expected renal failures to be old people, but I am surprised that renal failure is so common even in a younger age group nowadays. And this is all undetected hypertension. So you cannot, to give all of them care as CMCHIS is unaffordable if you do not reduce the load of cardiovascular chronic respiratory disease. It also won't save lives. Once a person has a heart attack, the fact that he can achieve is not the best thing. To prevent that is important. And it's always the combination. Like Makkalthediya Marutvam is a great scheme. But its effectiveness in health outcomes will be seriously limited if you do not have the referral backup in place, and that referral backup gets facilitated.
Sorry for the interruption, sir. With your permission, may I request a silence, please? Excuse me. The audience, please behave. Please keep silence. Because the topic is discussing may be not useful for you, but for other participants. Please be silent. You can't browse it from the internet.
And my apologies for standing between you and your lunch also. So I understand that, but this is a thing. And outcomes depend on sustained follow-up. So most care is not, CMCHIS only covers a procedure. It does not cover coronary heart disease. It covers a stent or a bypass surgery. But you need before and after. If you're doing a joint replacement, you need physiotherapy before or after. It is not covered by CMCHS. And to do that follow-up at secondary care is very inefficient and very costly. So the need for much more effective this is there on that. So the same point, so it is synergy is cost saving because routine follow-up, a lot of it. Why must a person with mental health disease line up at the medical college to get 2 weeks worth of drugs? If it is for consultation with the psychiatrist, one can understand. It is cost ineffective to provide care that way. In a country like Australia, 80-90% of this regular medication is accessed at the community level. Over here, it is 80% of essential medicine will be at the medical college level. And therefore, this synergy makes care much more affordable for a system. When we were not paying for tertiary care, it did not matter to us. Because some fellow takes the care. That is not the way government should be. But once we have declared a Chief Minister health insurance program and we are taking that burden of that care, we are unable to cope with both burdens unless we can see them together. And finally, I must emphasize that if we are able to take both of these together, then the right to health care becomes possible. Without this synergy, you cannot have. It is only fragmentation. People's right to health care, that entitlement is registration in your primary health center, the health and wellness center. A mandatory registration through which, if you are referred, the care at the higher levels will be free. And it will be efficient. And boards, the first three of it, in theory, already exists in Tamil Nadu. Tamil Nadu, I would say, is the problem of having universal health coverage without necessarily having universal health care. Everything is done. Everybody is covered. But having said that, your premature mortality remains extremely high. Maternal mortality is different, but premature mortality, and that is because of this gap. And these last two, when the budget allocation becomes, so now in CMCHIS, you are responsive to the volume of services. Yes. Volume of services that you provide. That same logic extends in right to healthcare to the entire range of services. And the second thing is that the referral is not obligatory. You cannot be turned away at the door. You have to be reached to next. So you go on breast cancer. For example, I know in JIPMER, sometimes waiting list can be 3 months. What does it mean to have an early detection of breast cancer if my start of treatment will be 3 months later? It means nothing. It's actually criminal in most parts of the world. It's a 28-day standard, non-punishable up to 6 weeks. That should be the standard. But that means JIPMER gets 63 new cases of breast cancer every week. How can it cope with that cumulative load unless there is a system of mandatory, obligatory referral where if your public system gap is there, you can bring in the private sector. That you can do now. You can see the complementary strengths. On one side, CMCHIS and another side, primary healthcare. This has a certain system of identification, that too. There is digital architecture. The public financing system should learn lessons from each other. There is a comprehensiveness in the primary care, the care packages. And whereas the CMCHS has an individual grievance redressal system, primary care has community-based systems in the form of the district health assembly, in the considerable engagement with local bodies, etc. So bringing it together, both sides of these halves into a program, this integration, and I'm going to take my liberty to make this comment, is more difficult at the level of the directors and easier at the level of the facility. The down you go, easier to integrate. The higher level you go, more difficult to integrate. But these are things that are essentially needed, and you do need a legal framework for that. So why is a right to healthcare desirable in a Tamil Nadu context? Firstly, that everybody needs to know an entitlement and where it can be exercised. If I have a ration card, I know where to go to get that rice for you. I can't go to any shop. Similarly, the establishment of a care pathway as a mandatory obligatory system is a cost saving and life saving device, preventing indebtedness, improving the financing of public institutions. That is all you are struggling with, and ensuring equity and social justice. It's also required, these are the larger political reasons, for preserving federalism. Otherwise, you're going to have a central act and it's not good for you. In many places, they don't have a public health system of this size and this depth, so they won't lose as much as you would lose if there is a privatization push that comes through. And therefore, if you need to even safeguard public health services, I think it is important that it is protected by a legal framework, ensuring public health services, fulfilling obligations, and we all aspire for a 1 trillion economy. Why do you need a 1 trillion economy if you cannot guarantee right to health care? And how do you get to a 1 trillion economy if you do not have right to health care? The CMCHIS also teaches you the terms of engagement with private sector. Simply put, it's voluntary, never mandatory. Try to make it mandatory and you will have the Rajasthan disaster. Rajasthan was a bad act, badly passed. You never should have tried to make it obligatory, and later on withdrawal is not the issue. And the way it is costed and priced, there are technical issues about it. So let me just conclude with saying the linkages across levels of care are essential in universalizing healthcare. The incidence of the three main consumers of the CMCHIS budget and the main causes of mortality both require the synergy between primary care and secondary care, and the challenges faced are completely similar in many ways, and we need to do that. We have, please, if you can note down, many of these things will be available on this website and these links. We have a regular thing on the problem solving and the challenges that we keep going on that. I think it is important that we keep ourselves abreast of the policy dimensions of our work and don't leave it to many of these work. And I would make a strong call for two good programs, but they need to come together to make it much, much better. Thank you.
Thank you, sir. So thank you, sir, and for the wonderful presentation on this interfacing the primary care with the CM insurance scheme. So as a public health administration and a state health administrators and my fellow district administrators, what the lessons learned from your presentation is the take-home message, sir. We are discussing about the premature mortality as well as the maternal mortality and many other factors. The scope you are giving right now is about taking this interfacing system, a synergy model of primary health care into the insurance scheme may help us, may give us an answer for this, decreasing the maternal mortality or the premature mortality also. So it's a very good eye-opener presentation for our district administration as well as state administration. We'll definitely take a call with the state authorities, sir. And again, you also said about the continuity of care, and the patient is not bothered which center they have to go. Ultimately, they need the continuity of care. With this, I think it's a great presentation from you, sir. And any questions from the audience, please?
Sir, good afternoon. I'm Dr. Ajit, District Health Officer, Mayiladuthurai. So, in addition to the points that have been discussed, I would like to bring to consider one more point into this scheme. So, the allocation of insurance amount that has been given to hospitals always neglects the primary care part. We do not receive any allocation from the insurance costs that have been recovered. So, for example, I will take the RBSK scheme. It takes a great deal of effort and time to mobilize children to have their cardiac surgeries done. There are unwilling patients who needs to be convinced, make multiple visits. So we do all these things. So when we finally get them to the hospital and get the surgeries done, the insurance cost is being claimed only by the tertiary care center. or the secondary care center where the surgery is being done. But the cost, the part of amount that I'm speaking is the upgradation, hospital institution development cost that has been allocated as a part of CMCHIS. So that's being given only to the primary care center. It doesn't include it doesn't include the primary care center. It is given only to the medical college hospitals or private hospitals where it's being done. The effort that's being put before that, it's completely being neglected. And regarding this is one point, sir. I need your inputs on that. The second point, still they are insisting on physical cards. We have come to an age where digital cards are being accepted. For example, I will take the driving license. Even the police have been begun accepting digital cards that are stored in DigiLocker, apps that are officially from the government of India. And I feel it's time to take these into the next level, apart from ABBA ID. Thank you, sir.
Thank you. I think the point on primary care linked costs is well taken. Other than what I am saying in the way we approach it in right to health care, it's difficult to give cost by cost for each referral. You would not like it because your paperwork will be too much compared to the money you get. The money you get will be small, the paperwork will be large. So people who do this financing do it in a different approach. They look at the total number of people of a particular category you save and give a lump sum cost to that. So yes, such financing should reflect your larger service. That is something that is important to bring about. But two, it need not be delivered in the way the classical fee-for-service insurance is delivered. So you get that. It is not there, but it should become there. The second was on, yes, on, if you ask the insurance, and I've asked as chairperson, according to them, it's already there. So you are saying it should be there. They are saying, no. If you give the number, we can detect the card. And since it is linked to ration card and Aadhaar number, if you link Aadhaar number or ration card number, we can extract the CMCHIS card number. You do not need to present these three cards as physical cards. However, in all humility, I agree that what you say is the problem. Though the rule-wise it is not there, in practice, insistence on a card is more common, on a physical card is more common than it ought to be. Some of it is what she will call informal forms of rationing. You have to find some reason to keep the claims low. But some of it is just pure, what shall I say, pig-headedness. They are just being stubborn. No. Actually, we should insist that the number, the production of a number, and any one of these three identities, Aadhaar, there is a problem, but they say for CMCHIS, that ration card, they go back and forth. From this to that or that to this is guaranteed. And you don't need the physical card. That is the contention. Okay? So we need to make sure that it is there in policy. I hope when the report comes out and some of these are part of the public domain, you can enforce these things better.
Got the answer, right? If my understanding is right, sir, to answer his question, he called us two answers. So one is the allocation to the primary health system. So if you follow this concept of synergizing the activity of primary care into the insurance scheme, definitely the procedures will be included in the insurance scheme. We may get the revenue of it. That's point number one.
But not through the insurance.
Not through the insurance, yeah. Again, the second point is about, we have the presentation from Rahul Pandey coming out with the integration of IT platforms. That may be a solution for your answers also. Thank you. Thank you. And
thank you for enlightening us, sir. We humbly request Director Nirmalsan, Joint Director MCH, Dr. Nirmalsan, Joint Director MCH, to felicitate Dr. Sundararaman. We also request you to felicitate the moderator, Dr. Vinay Kumar, sir. Thank you, sir.